After posterior spinal fusion for adolescent idiopathic scoliosis patients, there is alteration in trunk range of motion in the coronal, sagittal, and axial planes. Surface topography is a reliable tool for measuring spinal range of motion without radiation exposure. Studies have shown decreased range of motion in patients with greater fusion levels than may affect the range of motion between non-selective fusion and selective thoracic fusion. This study sought to determine the range of motion in overall spine in multiple planes measured by surface topography in patients with AIS undergoing posterior spinal fusion with en-bloc derotation across multiple postoperative visits. Additionally, this study aimed to determine whether patients with non-selective fusion will have differences in range of motion compared to those with selective thoracic fusion. Methods. A retrospective review from a single-center prospective IRB-approved registry was conducted. Inclusion criteria required subjects between 11 and 21 years of age at surgery, a diagnosis of AIS, and valid range of motion measurements obtained via surface topography scanning. Axial, sagittal, and coronal range of motion was performed at 6 time points: preoperative, 6 weeks, 3 months, 6 months, 12 months, and 24 months postoperatively. All patients had an upper instrumented vertebra of T2, T3, or T4, and a lower instrumented vertebra of T12, L1, L2, or L3. Generalized estimation equation modeling was used across time points for statistical assessment. Looking at Figure 1, range of motion in the non-selective fusion and selective thoracic fusion groups, notice that the percent differences are shown on the y-axis, and the 6 time points are shown on the x-axis. Differences between a particular time point and preoperative are illustrated as red, green, or black dots. The red curve shown for selective thoracic posterior spinal fusion is in the sagittal plane. The black is axial, and the blue is coronal. Similarly, in Figure 1 at the bottom are the same color codes for the sagittal, axial, and coronal curves across time points. This study included 54 patients, 40 patients in the non-selective fusion group, 65% female, average pre-op Cobb angle 56.4 degrees, 21.4 kilograms per meter squared BMI, and 15.4 years of age. 14 patients in the selective thoracic fusion group, 92.9% female, average pre-op Cobb angle of 57.4 degrees, 21.5 kilograms per meter squared, body mass index, and 15 years of age. At 6 weeks post-op compared to pre-op, sagittal plane range of motion decreased 28% and 21% in the selective thoracic fusion compared to non-selective. Axial plane range of motion decreased by 50% in the non-selective and 45% in the selective, and coronal plane range of motion decreased by 42% in the non-selective compared to 29% in the selective thoracic fusion group. At 24 months post-op, range of motion improved in all planes for both groups compared to pre-op period. Sagittal plane range of motion decreased 17% for the non-selective group and increased 4% for the selective thoracic fusion group. Axial plane range of motion decreased 25% for the non-selective fusion group and increased 6% for the selective thoracic fusion group. And finally, in the coronal plane, range of motion decreased 20% in the non-selective fusion and 26% in the selective fusion groups. Conclusions. Coronal, sagittal, and axial range of motion as measured by surface tomography demonstrated significant decreases from preoperative to postoperative following posterior spinal fusion. However, this deficit trends towards improvement over time. Our data suggests that both non-selective fusion and selective thoracic fusion patients improve their range of motion in all three planes over 2 years postoperatively. Improved long-term follow-up with larger cohorts will provide definitive data regarding the postoperative spine in terms of range of motion.